Welcome back to episode 11 of the League Trauma Podcast. Today we will talk about the past, present, and future of total joint replacements with Dr. Dave Lorenz. Dr. Lorenz is a PT for Atlantic General Hospital on the Eastern Shore, where he specializes in post-op day zero physical therapy. He brings a wealth of knowledge about everything leading up to a joint replacement, as well as what a same-day PT session looks like. We are so thankful for Dr. Lorenz giving us an hour of his time to talk about a very important topic in the PT world.
Dr. Dave Lorenz. I'm a physical therapist, been out in PT for about 5 years now as a treating clinician. Prior to that, I took a gap year after undergrad, before grad school, working as like a rehab tech. So I've kind of been in a PT clinic almost for about like 10 years now, kind of seeing how everything's run. Um, I got into PT mainly because both of my parents were in nursing. And I always knew that like healthcare was just something that kind of appealed to me. You always see family members that have gone through their struggles up and down, mobility, illnesses, things like that. And I just genuinely like helping people, like connecting on with them on a personal basis too. And then, when you get to see someone get better functionally too, I mean, it just really kind of drives your will to continue to do, the best job that you can be as a physical therapist.
Awesome. So let's hop right into it. Let's talk a little bit kind of so right now you're about to step into a position of like day one rehab. So let's talk a little bit about before they even get the surgery, like the importance of prehab and kind of what that looks like session to session before they do get that big surgery.
Yeah, so prehab is definitely something that's becoming more and more prevalent as the statistics are crazy as far as like joint replacements. I think you can look it up, but it's like roughly they're doing like 750,000 roughly like joint replacements a year. By the time like 2030 rolls around, they're going to be doing like just about double that. So like 1.5 million. It's crazy. People are living longer. So because of that, they're going to do more and more joint replacements, and people are going to have multiple joint replacements probably through their lifetime. So the big thing is, hey, how do we ensure success once someone has a joint replacement? And when you're talking about prehab, they're going to get the instructional classes as far as like, hey, this is what the surgery entails from the surgical team and things like that. They'll go over signs of infection, but for you as a therapist, it's okay, hey, how do I make sure that they're going to be okay in their home after everything is done? And I think that's a lot of things that get overlooked sometimes is that you need to go from like a full 360-degree view. Is like, all right, so what kind of car do you have? How is it going to be getting in, a sedan versus like if you have like a Ram 2500 truck or something like that? Excuse me. And then you're talking about tripping hazards throughout the house. You really got to educate the patient and their caregiver as well as, tape down or pick up any throw rugs, area rugs, dog toys, things like that. And then you're think about everything that we do on a day-to-day basis that we kind of take for granted as far as even when you get up in the morning, you get up, go to the bathroom, brush your teeth, and then, you got to go maybe up or down the stairs, just getting in and out of bed, being able to transfer from a bunch of different surfaces. So prehab is like, I know with my first visit, it's covering all of that. It's like, hey, this is how you're going to get up and down stairs with a walker and a cane, because some people might only be on a walker for, a week at most, before they're chomping at the bit to kind of transition to a cane. And then, you're just really trying to educate them on getting off and on the toilet, whether that's, hey, buy a commode, get ready for it. What kind of shower setup do you have? Do you have a step-in shower, or do you have to step over a tub? As someone that has had surgery, I know that like when I do like a tub step over, and that's like that blew my mind. I was like, how the hell am I going to get into this tub? So just telling them to invest in simple things like shower chairs, shower benches, things like that. So that's like the first main visit of a prehab, and then like the only other visits is like maybe once a week, you're just going over, hey, these are some basic exercises that you'll start to do. And then you're really just focusing on their form. And as far as like, you're really preaching getting them moving. Because the last thing that you want is them to sustain like a blood clot because they're not moving enough. And then we all know like the downside of, immobility. So you really got to preach and hammer home the fact of like, hey, get your butt up, get moving, control swelling, and just kind of get moving to stay loose, really.
Awesome, thank you.
Yeah, that's very cool. And I'm glad you brought that up, John Allen, because I was thinking like it's so important that prehab part, especially like the DME training and talking to the caregivers about like how they're going to be mobilizing or getting around because if you think day zero, they just got out of surgery. A lot of times, I guess there's the medication's still in them and they may not be with it. So if you're trying to explain, like, hey, this is how you're going to use this assisted device, they may not get it fully. But if you take that time in preparation, then definitely set them up for success down the road. It's a really good point. But the question I had is so getting into this, how often do you expect to be encountering upper extremity patients? Because, like, from my experience, and I don't have much experience, but I feel like from what I've seen in the acute care setting, OT tends to take all the upper extremity patients and focus on things like dressing and bathing and things like that, while physical therapy will take spine, lower extremity, and work on like balance, gait, transfers, and things like that. So, what's your take on that?
Yeah, I mean that's a very good point, Josh. It's one of those things where in like the hospital setting, that like acute care setting, like PT, you're probably not going to really see upper extremity just because you're talking about a hospital surgical team. I mean, there's PT, PTAs, OTs, OTAs on the team, so they're going to really take the upper extremity cases, but as far as like if you're in an outpatient setting and you get there, I mean, you are going to see a good bit of kind of shoulder or reverse shoulder replacements. I mean, honestly, though, if you're talking about hip, knee, and shoulder, I'd probably say it's only going to be maybe like 10 to 15% of your patients that you're going to see like shoulders. But it's still very important because as out of all those joint replacements, I mean, they've been doing hips and knees forever. And then shoulders, it's kind of newer. I say new within like the last 50 years. I mean, in medicine, that's like infancy. So that's, the fact that that's still kind of new. But again, as more and more people are living longer, I think they're going to continue to have an upwards trend in shoulder replacements. And then one that I think you're going to see more and more down the road too is I think, assuming outcomes get a little bit better, I think you're going to see some more ankle replacements too, as far as like individuals that have had like ankle fractures and they've had hardware in there for like 30 years. I mean, I feel like I'm hopefully not going to be on that road, but I know that, a lot of individuals that have had that hardware in there for like 30, 40 years, eventually they do end up getting like a full ankle replacement. But for the most part, to answer your question simply, I mean, in the hospital, you're not really going to see too many shoulder replacements, but still very important to know the difference between like a regular shoulder replacement and then a reverse shoulder replacement as well.
Absolutely.
Talking about the ankle, that's super interesting. You mentioned that. I assume that the I'm not very familiar with the like total ankle replacements and protocol like that. So are they on non-weight bearing protocols like following the surgery, or is it similar to like the hip and knee? They're just kind of like weaning their back as tolerated in the hospital.
For the most part, you're going to be non-weight bearing for at least for a little bit of time, just to kind of really let that kind of joint kind of settle in. And then it's almost like think of it like a slow, almost like Achilles process too. It's like you're in a walking boot, so you're non-weight bearing, and then once you are able to weight bear, you're going to be in a protective boot for a little while. It's just so super slow. I mean, you guys know the anatomy of the ankle. It's super complex. And then when you have like a full replacement going on, that's why they don't really do those too often just yet, just because the outcomes aren't that great as far as like overall mobility. However, I think that as our technologies and everything continue to adapt and improve, especially as we all know with like artificial intelligence and robotic surgeries kind of on the rise, I think they'll do that a little bit more. But I mean, the whole meat and potatoes is going to be really your hips and knees. And I mean, those are a breeze. And as you guys have seen, I mean, most hips aren't even getting to outpatient anymore. They're just going to prehab. And then sometimes I know when I was in Pennsylvania, surgical teams would give the patients like a disc, like a DVD, and just say, hey, these are your exercises. Go ahead and do it. That's entrusting a lot on the patient. I don't really know if I agree with that, but I mean, that's all the stuff that you got to be comfortable with.
Interesting. That's super interesting. Yeah, would just love to see the trajectory of the ankle total ankle replacement. That's super interesting.
Yeah. So my next question is, how do you go about developing or creating that immediate rapport with a patient, knowing that in the acute care setting, you may only spend a day, couple days?
Yeah, I mean that's a good question. It's all about really just kind of getting to know them because, like you said, it's when you're an outpatient, you have a little bit more time to kind of get to know them. But when you only have like a day or so, you just got to say, "Hey, I mean, I'll ask them straight up, like, what do you want from me as far as from this? I mean, what do you want to be able to do? Do you want to just be able to, hey, I live in a rancher. I only have like 2 or 3 steps to get in the house. I just want to be able to do that, walk around my house. Or do you have someone that's like, hey, I really want to have long-term goals as be able to like higher level athlete, things like that. I want to be able to go back to swimming, things like that. And then you just try to connect with them on a personal basis with that. It's like, oh, I enjoy doing that kind of stuff too. And then you just kind of give them tidbits of information. Obviously, you can't like load everything onto them at once because, like you said, they're still going to have like anesthesia and kind of be weaning off of it. So you just try to connect to them on a personal basis, like, hey, what do you like to do? What do you want to get back to doing? And I mean, that's 90% of this whole PT profession as a whole is just kind of getting to know the person and being able to connect with them on a personal basis. And that makes your job significantly easier.
Cool. Thank you.
So going off that, like when you are like sending the patient home, are you waiting for them? Are you just kind of matching their goals to their treatment, and then once they achieve those goals that you guys have set together, is that kind of when you're like, all right, like you're ready to go home to home health, or do you have other like objective measures that you would like them to see?
Yeah, I mean, the main thing to be able to, I mean, as we all know, as hospitals work, I don't know how in depth you guys know this yet, but like hospitals really make their money by getting the person in and out, right? So I mean, the same day discharge is like it's huge. So in order to really be able to be discharged, it's one that they tolerated the surgery fairly well. They're not having any adverse reactions to the anesthesia or things like that, and that they're just able to show simple kind of basic patterns of, hey, they're able to walk, say, 20, 25, 50 feet in order to be able to get up, go to the bathroom, go up and down a flight of stairs, and then being able to negotiate, kind of like a curb simulation too, because that may always kind of pop in into their life as well. So as long as they show that they can be safe with those kind of basic tasks, as far as like, and also bed mobility, sit to stand transfers, things like that, then you're going to be cleared for home health. And then home health, um, on average, they'll probably be there for like maybe 1 to 2 weeks. It really depends on how fast the person is progressing. And with home health, it's really just, hey, are you going to be safe in your home? Because I mean, as we all know, some home setups, like some people have like pristine, nice, clean cut houses. There's no clutter. Other people, like I did a home care rotation, and like the extremes that you see in their houses, it's like you don't want to call them like hoarders or stuff, but like there's like junk everywhere, and like you got to be like, all right, well, I mean, you can try to tell them to like clean up, but like no one takes well when you go in their house and be like, all right, you got to get rid of this, get rid of that. They're gonna be like, all right, settle down, dude. I'm not gonna listen to you. So it's one of those things where you just got to make sure that they're able to safely navigate everything in their house. And then, once they're at the point where, because home care, I mean, you don't really have equipment as well. So, yeah, I mean, once they're able to really negotiate everything in their house safely and effectively, then you move them to outpatient. But for acute care, I mean, you try to get them in and get them out the same day. If not, I mean, it only overnight, and then try to get them out to home care.
Awesome, thank you.
What would you say is the most important, like objective measures, day zero for a post-op patient? Let's say, I don't know, or knee replacement, because I know like obviously strength isn't going to be fully there probably, and then extension and flex, you're probably not going to have full range day zero. But can you talk a little bit about the objective measures that you're taking on day zero?
Yeah, objective measures. I mean, you're going to really more so rely on like your functional outcome testing as far as like being able to do at least a couple effective sit to stands, whether that's with some upper extremity assistance or not. And then you're going to look at just overall, the biggest thing is their gait. You're going to look at their gait quality, gait speed, because if you just look at their quality of gait, I mean, you can get a lot of like objective measurements just from their gait. Hey, are they lacking hip flexion? Are they lacking hip extension? How's their knee flexion extension during swing phase? How's the ankle dorsiflexion? So you're just kind of taking like a zoomed out approach. I think too often, especially I know I was guilty of this as a new grad too. It's like, all right, they had a knee replacement. I'm just looking at their knee. It's like, no, you want to take a step back and really kind of look at, the shoulders and waist all the way down, see if they're getting some good pelvic rotation, trunk rotation. And then, I mean, the gait is probably the most important thing as far as your objective assessments. And then, of course, bed mobility, making sure that, if not too many people are still doing the posterior lateral approaches with your hip replacements, but if they are, hey, are you able to get in and out of bed and do specific transfers while maintaining those hip precautions? And really trying to drive that point home to the patient and also make sure that their caregiver as well is there as well, because like we've kind of harped on before, is like you're going to be a little loopy, after you have the surgery. So you really have to educate the caregiver as well to kind of show them that, hey, they got to maintain these various precautions if there are any.
So you mentioned how people were getting older, so like that second joint replacement is kind of becoming more and more prevalent. So like, do you find it harder for the individual to rehab from that, or is it kind of just the same process and you just kind of just convince them to just buy into the PT and day zero and that kind of stuff? You talk a little bit about like the second joint replacement.
I would definitely say it's a little bit more challenging than the first one is. I mean, for simple, first and foremost, is that, they're older. So the recovery timeline is going to be a little bit slower. Mentally, it might be a little bit more draining on the patient as well. It's like, hey, I already went through this like 15, 20 years ago. I got to go through it again. But, again, it's connecting with those people on a personal basis. Like, hey, 15, 20 years ago, you might not have had grandkids, but now you have grandkids. So don't you want to be able to get into a good squat, be able to pick them up, and kind of be able to play with them? Not really, obviously, not like kneeling and crawling after them or anything like that, but just being able to do those kind of simple tasks that they want to be able to do. Overall, it's definitely more challenging. But I mean, it's one of those things where, you know, if they're taking good care of it, they may only need one throughout their life. But I mean, I think, then now they're doing, joint replacements. I think the youngest I saw was like, I saw a bilateral knee replacement of a guy like in his 40s. So I mean, you're figuring even if all goes well, he's probably going to need at least another one, if not two, kind of down the road. So I mean, it's one of those, you got to try to tell the patient like, hey, try not to think about that in the future, just enjoy what you have going on now. But I mean, overall, it's definitely an uphill battle to try to just have that patient buy in all over again. I mean, we see it in athletes all the time, right? I mean, a guy pops his ACL, comes back, and then pops the other one or suffers another injury. And it's just one of those things where you just got to try to get him to buy in as best as you can. I mean, PT is a lot of selling it to the individual and the patient. We're kind of like salespeople at the end of the day. So if you can do that, I mean, that's a huge skill to have moving forward.
So it's also kind of a similar path, like the contralateral replacement. Like, how do you like kind of navigate like saying it might not go the same, and like because a lot of times it might not go the same, and people get frustrated. It's like I hear it all the time. Like my left knee did so well, but my right knee is taking forever to rehab. So kind of like talk a little bit about how you're going to navigate that conversation and just kind of talking through that.
Yeah, I mean, that's a great question because you do hear that a lot. It's like, oh, I have my left knee scheduled for March, and then in June or July, I'm going to get my right knee done. They get their left knee done, it's a breeze. They're like, oh man, by the time summer's done, I'm going to be swimming, I'm going to be chilling on the beach. I'm going to be able to get up and down off a beach chair. It's important to remember that at the end of the day, it's still, I mean, what I try to tell patients, it's, hey, at the end of the day, you're still going through a significant surgery. So, I mean, it's not just like a lot on the joint itself, like your knee. It's a lot on it taxes your whole system. And as we know, with the stages of tissue healing, I mean, that tissue kind of remodeling maturation phase, that can be 1 to 2 years post-op before everything is kind of all settled in there. So, once, say if you have that mock patient that comes in that says, I have two joint replacements lined up within 3, 4 months of each other, it's important to say, hey, try not to compare one versus the other just because, say, the left one went so smoothly. Don't expect the right one to go as smoothly. And they might say, oh, well, Mr. Smith down the street had, the same thing and he was fine within a couple weeks. Again, you're not the same person. I mean, we're all different. We all heal differently. So it's really important. It's imperative, I think, to have that conversation with the individual. Be like, hey, I understand like this is a little bit more taxing, but think about it. I mean, say you had your left knee replaced. You're really relying on your right knee, and you might not even notice it. I mean, you're kind of compensating and favoring it. So you're already kind of accelerating the decline of your right leg. So at the end of the day, but when it gets time to have that right knee done, it might be in worse shape than the left one was previously. You might not really have pain because as we all know, pain science, your mind might be focused on, something else, but it's important to have that conversation because if you don't, they're kind of going in with like false expectations, and then who are they going to take it out on? They're going to take it out on you. And I mean, nobody likes that. So it's important to kind of get at the forefront of that and just be like, hey, listen, like, I understand it kind of sucks that this may be happening, but this is all part of the process. Doesn't mean anything's wrong. It's don't expect everything to go as smoothly as it did the first time around. That's a good question, though.
Yeah, thank you.
I was wondering if you ever been in a situation as to where like maybe a complication occurred within the operating room, like say maybe nerve damage or something, and then how'd you go about handling that? Or if not, like how would you go about handling that?
I haven't actually like seen it in the operating room, but like I have seen it like a handful of times where, sometimes because if you look at like the nerves, especially like the knee itself, if you look at around like the sensory nerves of your knee, it's super, super complex. So it's one of those things where that's why I always try to ask the patient, like, hey, how's your feeling around your knee? Is it feeling okay? Because sometimes, hey, we're all human at the end of the day. So sometimes the surgeon may cut like a sensory nerve. And as we all know, like sometimes they do regenerate. And if they do, it's super, super slow. So it's one of those things where they might ask you first because as we all know, I mean, their follow-ups with their surgeons are kind of, you got 2 weeks and 6 weeks post-op, and then they might not see him for, 3, 4, 5 months and then a year out. So it's one of those things where they're going to ask you, hey, am I going to get that sensation back? And as we always hear in PT school, it depends. It may come back, it may not come back. But it's important to just kind of tell them like, if you have like a little 2 inch diameter where you can't really feel sensation on the inside of your knee, is that really going to impact your quality of life? Probably not. But I mean, the biggest complication to kind of go back to answer your question is just signs of infection. I mean, the things that you really want to kind of be on the lookout for, especially even an outpatient. I mean, I've seen it before. Things may be going well, but sometimes as we see like surgical incisions, they could be even open like a split millimeter or two, and say like, a piece of dust or something from the house particle kind of gets in there. I think it was like Alex Smith is a good kind of comparison with this, is like any little small particle can cause a cascade of events. So like if the person just complains of like lethargy, where they're just like very sluggish, they're running a fever, it's really, really hot to the touch, that's something like, don't wait on it. I'd rather, you be kind of ringing the alarm bell to say, go get this checked out, instead of just being like, let's wait and see. It's better to just, be that person to say, I'd rather you get this checked out ASAP before anything could possibly go wrong. But that's going to be the biggest thing that you're going to be looking out for.
Thank you.
You mentioned like the surgeon kind of the follow-up dates in like 2 weeks and 6 weeks. And have you ever like ran into an opportunity where like kind of the surgeon's not progressing them as well as you kind of feel like they're progressing in the clinic? Like you're seeing them 2 or 3 times a week in the outpatient clinic, but the surgeon is still like no, like I don't agree with like kind of like progressing at the rate that you're going. Like how do you kind of navigate that and also like combat with the patient getting pulled from two different ways?
Yeah, I mean that's another thing that especially when like you guys come out of school and like being like a new grad, that's something that I didn't really think about at first, but as you get out into your career, it's very, very important to be on the same page with the surgeon and their team, whether it's, the physician. Very like it's going to be here and there that you're going to actually be talking to the surgeon. It's going to be more of like their PA. So it's one of those things where even if you just give them a call, just say, hey, I saw, Mr. Smith for his total knee. You did a great job on it. This is what we're looking like. This was my plan for him kind of moving forward. And if they are, as long as you're upfront about it, they're going to be okay with it because at the end of the day, if you are progressing them fairly quickly, it looks good on them too as the surgeon. Like if they can be like, oh man, like Dr. So and so did my knee, and within 8 weeks I was pain free, with not using an assistive device, doing everything that I wanted to do. So communication is huge with that. It's going to be different when you're talking about like ACL tears and things like that and reconstruction. That's another thing where, when the patient shows up, I would say, hey, did they give you a protocol? Because as we know, some are a little bit more aggressive, some are conservative. So sometimes it's just one of those things where it's a simple phone call, whether it's yourself, where you get like a front desk person to call and say, hey, just call the doctor's office and ask them, like, is there any specific protocol you want me to follow? Or do you just kind of want me to do my own thing? But I mean, even you making that phone call, the surgeon's going to applaud you for that because they're going to show that, hey, this person's actually invested in their rehab and recovery. So they'll be in good hands. And that's really all the surgeons care about at the end of the day is making sure that their patients are going to be in good hands. And, we all know what we're doing, but we just want to make sure that, we're making them happy too and fostering those relationships. That's going to go huge for your career.
Awesome. Thank you.
All right, so talking about like an individualized approach. So I know like post-op, there's certain protocols you have to follow. I know you like say you have to get quad strength back, have to get extension back, but how do you individualize a treatment plan early on as opposed to like I know later on in therapy when they're however months out, we can get into like more sport specific tasks if that's what they want to get back to doing. But how do you individualize it early on instead of kind of like just following a strict protocol, if there's any way you can, or do you just follow that protocol?
Yeah, I mean that's a really good question too. It's one of those things again where the first day, I mean, your initial evaluation, I think sometimes that gets a little bit overlooked. I know in PT school, they're always like, oh, you got to do X, Y, Z, cross all your T's, dot all your I's with your initial evaluation. Your initial evaluation, you really want to just understand the individual. So, I mean, I try to ask them like, hey, what do you want to get out of therapy? And sometimes they'll give you a generic answer like, oh, I just want to be able to walk or have less pain. It's like, okay, I get that, but like, what else do you want to be able to do? Like, is there anything specific that you really enjoy doing? Whether that's, you like going fishing and you want to be able to stand on a dock for, 2 to 4 hours to be able to, be able to fish and just be at peace. And when they give you that kind of answer, and then you're formulating like a home exercise program, it's one of those like you don't want to just give the same cookie cutter thing to every single person. You want to ask them like, hey, if I were to give you some exercises to do at home, which ones are you going to be more likely to do? Are you going to be, standing at your kitchen counter while you're cooking dinner, being able to do, a couple exercises, or when you're in bed, before you get out of bed first thing in the morning, is that going to be when you're likely to do these exercises? So that's like the biggest thing that I would recommend is like that first day when you're evaluating someone, try to get to know them as best as they can, because if you're just throwing stuff at them and they're like, I'm probably not gonna do this, then you're just setting yourself up for failure. So it's one of those things where try, like you said, individualize it to the patient to be able to say, hey, what's going to be, more likely for you to be able to do in order to kind of have the best outcome.
That's a really good point because I feel like from what I've learned so far, not to put anybody down, I feel like those cookie cutter exercises early on are just thrown out to patients. And like we don't really consider what if the patient doesn't even sleep in the bed? What if they sleep in the recliner and they never lay all the way back, but you're telling them to do this exercise when they're laying in bed? So like more than likely they're not even going to do it. So I think that's a really good approach. Thank you.
Yeah, of course. Yep. And I mean, that's the biggest thing. It's like get to know your person and your patient in front of you and just be like, hey, what are you going to be more likely to do? You don't just want to throw everything at them because then, I mean, in reality, they're going to do maybe half of the exercises that you give them. So just try to have like a gold standard of like, hey, we might have like 10 to 12 exercises that we know are very important for you to do, but try to get to know the person and say, all right, these are the two or three that I really want you to do every day, whether that's, doing some squats at the kitchen counter, doing like three sit to stands, like, hey, before you go fill up your glass of water, do three sit to stands off the couch before you go to do it. So just simple things like that you can try to sprinkle in.
Yep.
Yeah, I feel like that's even more like fun for you as a therapist. Is like if you're given the same exercise and you're seeing the same thing over and over again, it could be kind of repetitive and not as engaging for you as well. It's like why not let the patient kind of dictate the plan of care and then put my professional opinion and take on it to make it more fun for me and more functional for the patient. That's a great point. I agree as well. So we have 7 minutes left. Do you have any questions for us, or do you have any kind of like final statements you would like to just kind of wrap up this podcast with?
As far as questions for you guys, what would you say is something that I know you guys are what in your second year as far as like schooling and everything? What is like one or two things moving forward that you guys definitely want to kind of learn and be prepared for? Because you may not know, once you get out into the real world and you're treating clinicians, I mean, your learning opportunities kind of get few and far in between. So I mean, what is something that like you guys really want to kind of sharpen or learn before you guys graduate?
I think for me personally, it's kind of going off of what we just talked about, like taking that individualized approach. I feel like we're such like textbook driven right now in the way we're being fed information that we feel like there's a certain way to do everything for every single individual. And I know that's not right. So I think that's something that I definitely want to sharpen up moving forward.
Yeah, I completely agree with Josh. And then also just like more return to sport, return to like discharge kind of activities. Cause like right now I feel like I have a really good baseline. Like you said about just like the cookie cutter, like, all right, I progress from this to this to this. But then how am I going to progress him or my other patient from my last day to being returning to what he wants to do at home, he or she wants to do at home. But I think the return to sport, return to function level of therapy is kind of something that I want to sharpen and kind of learn more about. Yeah, and then just the Q care. I haven't been in a Q care yet, even for my shadowing hours or in grad school yet. So kind of seeing what like real life scenarios of inpatient and acute care rehab is all about. So those are probably my two things.
Going off of that, I haven't been in like home health yet. So I want to be able to like be more flexible with my treatment, like walking into a place, say I don't have a lot of tools or with me, I have a small bag and I need to create a treatment plan on the spot for a patient. I feel like that's something that I definitely want to work on and learn more about moving forward.
Yeah, and I think that's a good point too, is that in like if I could just say like a few things, like use your creativity to your advantage. Like you don't really need crazy equipment in order to be able to have a patient go through like a good rehab program. Think about like, and this will help too, because I think I was telling this to John Allen too. It's one of those things where school is all about getting you ready to pass and just pass the boards, pretty much graduate, pass the boards, be a treating clinician. But you got to be able to know that everything and everyone's a little bit different, like you said, with your individualized approach. So, they don't need crazy machines, crazy weights. Think about like simple things like, hey, I can progress things from just going from doing things bilaterally to unilaterally to doing things from an even surface to an uneven surface, eyes open, eyes closed, kind of really challenging their kind of proprioception, neuromuscular control, things like that. And I mean, it's one of the things that unfortunately with school, that's kind of it is very textbook heavy and things like that. But always try to keep that in the back of your head. It's like, yeah, we're learning all this in school, but when you get out into the real world, it's just not all of that kind of cut and dry. Because if you're just doing that same approach over and over again, I've seen it. I've worked with a lot of different people too. Unfortunately, sometimes people don't get out of that like school mode brain And I mean, it kind of hurts them as a therapist because then the patients are just going to be like, I could do all this like at home. Like I don't need to show up 2 to 3 times a week. The fact that someone is seeing you on a consistent basis, that means that they trust you and your knowledge. And I mean, that's the thing that we all strive for at the end of the day. It's like, hey, you trust me enough that at the end of you were a stranger to me, but yet you invest 2 to 3 hours of your week to come in here and listen to what I have to say. And I mean, that's kind of like the most rewarding thing that I can really think of.
Yeah, for those of you who don't know, I studied under Dave for a few weeks, and that was one of the biggest things that he just kind of hit home with me is like, don't be the textbook, and just continue to learn and adapt and learn from your patients, as well as like similar to like with documentation, like you just gotta let everyone know, let the insurance know that what is happening in front of you is translating from the clinic to the documentation. So yeah, it was a pleasure learning from you, and it was a great talk. I learned a lot. Any other closing remarks?
One last thing, just like with treatment, like everyday treatment, like even like if you're working an outpatient, just because you have an exercise program for them doesn't mean you have to rock through that every single time. Just because they show up today doesn't mean you have to do long arc quads, with the same weight and resistance. They may come in and be like, hey, so especially like me being down here at the beach, one of the biggest things is like, hey, so I was walking on the sand yesterday and I noticed that my balance was a little iffy. I didn't know if I'd be able to get up and down off of like a beach chair. Always be able to adjust on the fly. That's going to be the biggest thing, like as a PT moving forward. Just be flexible and be always willing to kind of change your approach, because if nothing changes, then nothing is going to change. So always be willing to change your treatment strategy, and you guys will be fine. You guys will be great therapists.
It's a great point. Thank you, Dave. I appreciate it.
Yeah, thank you for your
Yeah, man, of
time.
course.
It's been a pleasure. It's always great talking to you and learning from you. So I appreciate it, and thank you again for joining us.
Yeah, one last thing. Who do you guys got winning this weekend?
I hope Detroit wins it all, man. I really do.
I would love that, but I feel like the Ravens. I mean, the Ravens and the Niners kind of got lucky, but the Ravens have just been such a juggernaut this year. So I think the Ravens might do it, but I'm with you. I'd love to see the Lions, but I don't know. We'll see. Should be good games though.
Take Detroit and Baltimore.
Man, that'd be a good one.
Absolutely.
Awesome, man. Well, enjoy the rest of your night. Thank you again, and I'll be sure we'll be in touch.
All right, thanks, guys. It was a pleasure. Thanks for having me on.